I'm Mark Pegram, a medical oncologist from Stanford University, and I'm pleased to present to you today a lecture entitled Evolving Strategies in the Treatment of HER2-positive metastatic breast cancer with Antibody-drug conjugates and tyrosine kinase inhibitors. I want to acknowledge the input from CancerNet, who helped with the organization of this presentation today, and this activity is supported by an independent educational grant from CGEN. The learning objectives for this presentation are as follows: to explain the pathophysiology of HER2-positive metastatic breast cancer, mechanism of action of antibody-drug conjugates and tyrosine kinase inhibitors, and its therapeutic potential, assess new and emerging therapies for patients with HER2-positive metastatic breast cancer, apply current guidelines and best practices as appropriate to the care of patients with HER2-positive metastatic breast cancer, and finally, to recognize and manage adverse effects associated with new and emerging therapies for HER2-positive metastatic breast cancer. I'd like to begin with an overview of the pathophysiology of HER2-positive metastatic breast cancer and some therapeutic strategies that have been devised to target the HER2 proto-oncogene alteration in human breast cancer. Please note my disclosures for this activity at the bottom of the slide that are relevant for this presentation. That is AZ Daiichi, Novartis, Seagen, Genentech Roche, and my spouse is employed by Loxo at Lilly. Now, in terms of treatment for patients with HER2-positive metastatic breast cancer, the goals of treatment are the same for HER2-positive disease as they are for HER2-negative metastatic breast cancer. That is, prolongation of survival when that's possible. However, despite the plethora of treatment modalities available for metastatic breast cancer, significant survival differences are still relatively uncommon, and for most, sadly, cure remains elusive. There are some HER2-positive exceptional responders with metastatic breast cancer who are apparently cured of their disease despite metastasis. Moreover, there are some patients with oligometastatic disease at the time of diagnostic presentation, and sometimes there can be ablation, let's say, of a solitary hepatic metastasis, et cetera, that can also yield treatment with curative intent and sometimes apparent cures in the clinic. Symptom relief is paramount. Not as much attention is given to this as is merited based on my experience. So that's also really critical in the management of HER2-positive metastatic breast cancer. Maintenance of quality of life. This should also be paramount, but all too often we see the treatment side effects can be as bad or even worse than disease-related symptoms. So there's a constant tension between therapeutic intent and the efficacy goals that can be achieved as a result of therapeutic efficacy versus the toxicities of some of our treatments, which, if not managed appropriately, can be problematic with patients. So it's critical to be open, honest, to have a lot of communication with patients so that you have a complete understanding of what their symptoms are vis-a-vis drug-related adverse events. Delay until need for treatments with untoward side effects. For example, a delay until the time needed for chemotherapy, a delay on the need for radiation therapy for, let's say, bone metastasis or brain metastasis, neurosurgery for brain metastasis. Sometimes both neurosurgery and stereotactic radiation are used for brain metastasis, for example. So this is also a clinically meaningful endpoint. If you can delay the time until interventions that are associated with higher risk and higher probability of adverse events, that is also an important clinical endpoint in metastatic disease. And finally, improve progression-free survival. This metric includes both patients who achieve an objective clinical response, but also those who may have stable disease for prolonged time periods. That can also be clinically meaningful in terms of clinical benefit. So I'd like to begin with a historical perspective of the HER2 alteration. At the end of 2019, the Lasker-DeBakey Prize was awarded to these three gentlemen: Axel Ulrich at the Max Planck Institute for his work on the cloning and sequencing of the HER2 gene when he was at Genentech back in the early 1990s and late 1980s. Dennis Slayman for his discovery of the HER2 gene amplification event in breast and ovarian cancer, first published in Science in 1987, and then a subsequent follow-on paper in 1989 in Science. Dr. Slayman described not only the gene amplification event in about 15 to 20% of breast cancers, but also its association with poor clinical prognosis. suggesting that it may play a role in the pathogenesis of breast cancer and not merely be an epiphenomenon in human breast cancer. And finally, Mike Shepard's lab, including Brian Fenley, Paul Carter, Len Presta, who developed the mouse monoclonal antibodies directed against HER2, and then Paul Carter and Len Presta did the antibody humanization work, resulting in the final drug product, trastuzumab, which was first approved by the FDA back in 1998 for treatment of metastatic HER2-positive breast cancer. Trastuzumab was the first biologic approved for breast cancer. It was the first humanized monoclonal antibody approved for any cancer type. Since 1998, over 2.5 million women have been treated worldwide with trastuzumab, and that number is increasing. In fact, it's expected that the use of trastuzumab will be increasing globally because of the advent of trastuzumab biosimilars. And typically we see expansion of markets globally when more reasonably priced biosimilars become available for biological therapeutics. Trastuzumab is on the World Health Organization list of essential medicines. And finally, there's an overall survival benefit, both in early stage HER2-positive breast cancer as well as metastatic HER2-positive breast cancer with the use of trastuzumab when combined with chemotherapy. So historically, HER2 overexpression, as I mentioned previously, was shown to be associated with a poor clinical prognosis prior to the advent of HER2-targeted therapies. And this study is based on data derived from a 2003 study of breast cancers. And you can see the HER2-negative group fares much better than the HER2-positive group. And the p-value is highly significant here. And so this was really a formidable challenge in terms of the development of HER2-targeted therapeutics to try to overcome this poor prognosis. And this is due to the fact that HER2 is associated with decreased expression of steroid hormone receptors, increase in the S-phase fraction and Ki-67, higher nuclear and overall cellular grade, increased probability of lymph node metastasis, increased T stage is associated with HER2 amplification, and also the risk of distant metastasis is increased with the HER2 alteration. And finally, in metastatic disease, the risk of brain metastasis is increased by HER2 gene amplification. Indeed, in metastatic breast cancer, eventually about half of all patients with HER2-positive metastatic disease will develop HER2-positive breast cancer brain metastasis. Now, when Dr. Slayman first published his data in 1987 and again in 1989 in Science, it was controversial. And the HER2 story went through Arthur Schopenhauer's 3 stages of truth regarding new discoveries in human history. First, according to Schopenhauer, new findings in human history tend to be dismissed. Second, they are often ridiculed, even violently opposed. And third, typically those most opposed to the original claim say they actually first discovered it. And another one of my favorite quotes from Schopenhauer is that talent hits a target no one else can hit, and genius hits a target no one else can see. And so the HER2 alteration went through these phases where in the life cycle of a tumor marker, historically, we've seen this with other markers as well, not just HER2. We see positive results published in high impact journals initially, followed by maybe mixed results in, let's say, lesser journals. And then eventually somebody does a meta-analysis at the end of the day, and the ultimate effect and the truth, indeed, will eventually emerge through the process of scientific interrogation, which is healthy. I mean, this should be the case. New findings should be challenged, but it's kind of a painful journey to see lots of negative data. If you look at literature published in the early 1990s, you'll find a number of negative papers saying that HER2 isn't even amplified in breast cancer in some cases, and that in other cases, it's not overexpressed and that it's not associated with prognosis. So why is that? Why did we go through this painful episode back in those days? And Mike Press at the University of Southern California did some work in this area to try to understand why some of the early papers were negative. Many of those papers used immunohistochemical staining as the basis for their detection of HER2 amplification and overexpression. And what he found was that a number of these antibodies shown on the right-hand side of this graph when you characterize them against a very well-characterized group of human tumors that have been extremely well characterized by immunostaining and by fluorescence in situ hybridization to calculate the exact HER2 copy number, what Dr. Press found was that in many of these papers, the HER2 antibodies used for immunodetection of the protein were not very sensitive. And so consequently, there were a lot of false negatives, and that gave a false impression in some of the published data that HER2 is not overexpressed and is not associated with prognosis. And we now know that those papers were flawed by the use of reagents that were not well validated prior to publication. This is not restricted to immunohistochemistry. Here's a paper published in the mid-2000s, a paper that was done on a cohort in a lapatinib clinical trial where it appeared at first glance that HER2 negative patients were maybe benefiting from lapatinib, and that was not hypothesized originally, although lapatinib does block EGF receptor as well as HER2. So there was some enthusiasm that maybe by the dual blockade of both HER2 and EGF receptor, there could be some benefit even in HER2 negative patients. And so Dr. Prest asked to see the fluorescence in situ hybridization data, which characterized the amplification status of these tumors. And he was shocked to find on the left-hand graph that the ratio of HER2 to chromosome 17 centromere was almost always 4 in this cohort of 160 patients. And what are the odds of that? And this was done in a high volume commercial reference laboratory with name recognition in the field. And so Dr. Press asked for those samples, and he repeated the same analysis in his laboratory, and those results are shown on the right. And here you can see that the HER2 to chromosome 17 ratios had a wide distribution, almost a Gaussian distribution there within the circle. And so this is more likely to be truthful because the HER2 ratio is not always 4 in HER2 amplified breast cancer. And so this was an example of a laboratory technician who was not actually counting the signals in the nuclei, but was just calling all the ones that appeared to be amplified at a glance. He gave them all the same ratio of 4. And when you actually did the granular analysis, the truth emerged, and lapatinib was not found to be associated with responses in HER2 negative disease as a result of the final analysis. So now the ASCO and College of American Pathologists have convened a series of conventions of pathologists, clinicians, and experts, technical experts on HER2 testing. And as a result, there is now more formal guidelines established for HER2 diagnostics in the clinical field. Next, we were concerned and wanted to understand why the HER2 alterations seemed to be appeared to be related to poor clinical prognosis, and try to understand this situation better. We did a series of experiments in the laboratory where we transfected in HER2 into HER2 negative breast cancer MCF7 cells. And on the right-hand side of the slide, you can see that when we enforced overexpression of HER2 to the same level that is seen in HER2 gene amplification, these cells have about 1.5 million receptor protein molecules per cell, and that's typical of HER2 amplified breast cancer, which has upwards of about 2 million copies of the HER2 protein per cell. And you can see that in the upper right-hand side photograph that there's a marked increase in anchorage-independent growth in soft agar when you overexpress HER2. So a marked increase in proliferation. In the bottom right-hand side of the slide, you can see there's also an increase in tumorigenicity when HER2 is overexpressed. The left-hand side of the slide shows an example of a fluorescence in situ hybridization experiment where the HER2 gene is labeled in red and the chromosome 17 centromere control is labeled in green. And you can see that there are these clouds or clusters of HER2 genes. And as you focus up and down in real time on a fluorescence microscope, you can actually count the number of spots of each of those probes and come up with the ratio. We also tried to block HER2 to see what impact that would have. Having shown that HER2 overexpression causes proliferation, we then showed that blocking HER2 with an antibody actually decreases proliferation. And that's shown on the lower right-hand side of this slide. In HER2 amplified BT474 human breast cancer cell lines, you can see the S-phase fraction is markedly attenuated when you add trastuzumab to those cells. And this was not seen in HER2 negative control cell lines, which is shown in the publication site at the bottom right. Moreover, the mechanism appears to involve ligand-independent disruption of HER2, HER3 complexes, and that's shown in the upper right-hand side of the slide in an immunoprecipitation Western blot analysis where a precipitating antibody is used to pull down HER2, and that will pull down any other proteins that are in a complex with HER2, and you can see that HER3 is in that complex in the absence of trastuzumab. A positive control, which is the HER3 ligand heregulin, is shown on the far right of that Western blot on the top row. But as you can see from left to right, as you increase the concentration of trastuzumab, the association between HER2 and HER3 is diminished. The left-hand side of the slide shows the crystal structure of the trastuzumab Fab fragment bound to the HER2 extracellular domain. So now we know and understand exactly where this antibody binds and its mechanism of action. That gave us a lot of insight into the clinical utility of the molecule, given this better understanding of mechanism of action of trastuzumab. Well, ultimately, over time, the truth about HER2 emerged with regard to its association with poor clinical prognosis. If you look at microarray expression analysis in these breast tumor subtype predictions, you can see even based on these hierarchical cluster analysis of gene expression array data that the HER2 positive group has a higher incidence of metastasis compared to non-HER2 enriched breast cancer phenotypes. So even using RNA-based array technology, the HER2 alteration was shown ultimately to associate with poor clinical prognosis. And now we know that HER2 is a validated clinical target on this basis indeed. Another mechanism of action of trastuzumab that's worth noting is on the opposite end of the antibody molecule from where it binds to the HER2 receptor target. This is in the Fc domain. And the Fc domain can engage activating Fc gamma receptors. On the left-hand side of the slide, you can see the crystal structure of a human IgG Fc domain interacting with the human Fc gamma receptor R3A, also called CD16A. And when that binding occurs on immune effector cells, for example, NK cells or monocytes, you can see on the right-hand side of the slide that the cell killing is markedly increased when you add these human immune effector cells to a mixture of tumor target cells that are HER2 positive, along with trastuzumab in therapeutic concentrations. So this is antibody-dependent cell-mediated cytotoxicity, or ADCC for short, and this is another proposed mechanism of action of trastuzumab that has been exploited clinically. More about that later. Now, when we first were introducing trastuzumab into the clinic in the very first in human phase 1 clinical trials, we didn't know much about HER2 or the antibody in terms of its mechanism, its crystal structure, et cetera. We didn't have all that technology back in about 1991 when these first in human studies began. So we knew the target was HER2. We didn't know the mechanism of action of trastuzumab at that point. We didn't know what dose to start with. We didn't know what schedule to give the antibody on, whether it should be weekly or every 2 or every 3 weeks, et cetera. We had no idea about safety signals. We knew what the HER2 expression level was in normal adult tissues, and we knew it was expressed in a number of different epithelia. So we were worried about toxicity to other organs initially. It's also expressed in skin, for example. We weren't sure whether the humanized antibody would still be immunogenic or not. We didn't know whether to give the antibody as a single agent or whether to combine it with other effective therapies like chemotherapy or perhaps endocrine therapy in cases of steroid receptor positive patients. We didn't know the clinical setting to begin with as an ideal. So of course we started with a heavily pretreated metastatic disease, but we didn't know whether it should be a metastatic disease drug or an early stage diagnosis drug, a neoadjuvant drug. We had no idea. And finally, we didn't know what the optimal duration of therapy was. So we wanted to avoid the photograph on the right where a new technology is invented, but you don't optimize its best use in the clinic. So we didn't want it to wind up like this antenna on top of this vehicle here. We wanted to be more clever and have some strategy for clinical development. So we went into the laboratory. We did experiments in vivo in HER2-positive breast cancer xenograft models, and we found that the best outcome in vivo in these mouse models occurred when the target trough concentration in the mouse was around 10 to 20 micrograms per milliliter. So that became a target for us in the first in human phase 1 clinical trial in humans, where if we could achieve that level that was associated with the greatest efficacy in mice, that was kind of our first goal during the dose escalation of trastuzumab, and we did indeed achieve that goal and more. So this was very impactful in terms of kind of setting a foundation for PK analysis of trastuzumab in humans. We also know that the extracellular domain of the HER2 receptor molecule can be proteolytically cleaved at the cell surface, and that you can measure the extracellular domain, or ECD, of HER2 in the serum of patients with metastatic breast cancer. And we found in our studies that the level of the HER2 shed extracellular domain actually impacted trastuzumab pharmacokinetics. Here you can see a plot of the log of the trastuzumab trough concentration versus the log of the free shed HER2 extracellular domain. And you can see there's a direct inverse correlation between trastuzumab concentration and high levels of the HER2 extracellular domain. So we knew that this could be a potential sink when you give trastuzumab. Consequently, we developed the concept of a loading dose followed by a maintenance dose in order to overcome this sink. And that was introduced early on in the development of trastuzumab as a result of this HER2 extracellular domain sink phenomenon. In terms of drug-drug interactions, we coined the term of receptor-enhanced chemosensitivity because we found that a number of drug classes are synergistic when combined with trastuzumab. In this example, cisplatin was shown to attenuate DNA repair, shown by autoradiography over the nucleus of HER2-positive breast cancer cells. On the left-hand side are HER2-positive breast cancer cells treated with cisplatin. And you can see that as the platinum DNA adducts are excised and repaired by the platinum excision repair pathways, that there's a marked increase in incorporation of a tritiated thymidine probe. And you can actually count these spots to quantitate DNA repair after platinum in this assay format. However, on the right-hand side of the slide, you can see that with prior incubation with trastuzumab, that DNA repair and excision of platinum DNA adducts is markedly attenuated. Moreover, we measured an increase in elemental platinum in DNA extracted from these cells using atomic absorption spectroscopy. And so we showed that platinum resistance can be overcome by pre-incubation with trastuzumab. And that's the basis for not only platinum, but also for alkylating agents and ionizing radiation as well, in terms of this mechanism of synergy between chemo and trastuzumab. Here's some experiments where we formally measured drug-drug interactions using isobologram analysis. This was an alkylating agent plus a trastuzumab antibody. And the combination index is defined as synergistic whenever the combination index is less than 1.0. And you can see that across a wide concentration range spanning the inhibitory concentration 30% all the way up to the inhibitory concentration 70%, that there was a marked synergy with an alkylating agent and trastuzumab in this experiment. The correlation coefficients are all north of 0.95, so this is a very tight experiment in terms of confidence intervals, and this was highly statistically significant as we published in a paper back in the late 1990s. This is true with a number of other DNA damaging agents and some other drug classes as well. Next, we tried to understand the order and timing of administration of trastuzumab with chemotherapy. In this experiment in mice with the drug platinum, we found that the best results were when you give both simultaneously. But when we staggered the injections between 8 hours, 24 hours, 72 hours, and 120 hours, the results were always better if we gave trastuzumab prior to chemo during those intervals. That is, the shaded boxes yielded smaller tumors across the board here at all those different time points. Whereas if we gave the chemotherapy first, the tumors were larger at the conclusion of the experiment. So it's best to give both simultaneously. And to this day in the clinic, we typically give the antibody first prior to giving cytotoxic chemotherapy. And that's based on this experiment done back in the early 1990s. One of our biomathematics graduate students, Angela Lopez at UCLA, came to us and developed a new method to measure drug-drug interactions in vivo. It's very hard to use combination index isobologram methods in vivo in mice because it would take thousands of mice to measure multiple drug classes. But Angela came up with a method using the data sets that we had already established in the laboratory. And the top of this equation on the left is actually the Gallen-Parts equation. Then there are negative growth terms for trastuzumab, which is an H, and this experiment was done with doxorubicin. So there's another growth term for D, doxorubicin, which is the lower term in that equation. She also was able to capture the order and timing of administration. This is one of those experiments where giving trastuzumab and doxorubicin on different days versus on day 0 simultaneously. And so this model-based approach offered a quantitative definition for additivity. Once she came up with equations for both component drugs, you can simply add the two equations to come up with an additive line. And if tumors at the end of the experiment are smaller than that, then there must be synergism between the two drugs vis-a-vis tumor growth inhibition. And if they're above the additive line, they must be working less than additive in those subjects. So this method accounts for the order and timing of drug administration and avoids problem of naive data averaging from univariate data summary. So this was her thesis work was published in the Proceedings of the National Academy of Sciences based on these experiments. So this also was very helpful to us in terms of clinical development. Ultimately, the experiment of chemo plus trastuzumab worked both in metastatic disease and is shown in this slide in the early disease setting, where trastuzumab plus chemotherapy yielded a disease-free survival hazard ratio of about a half with high statistical confidence with a p-value of 10 to the negative 12th. There was also a survival benefit when trastuzumab was added to anthracycline and taxane-based chemotherapy with a hazard ratio of 0.67 and a significant p-value of 0.015. So our efforts paid off in the end with an improvement in disease-free and overall survival in early breast cancer and an improvement in time to progression and overall survival in metastatic disease as well. Now, that experiment I just showed you in the clinic was done with anthracycline-based chemotherapy, and what we found was that there was a risk of cardiotoxicity related to trastuzumab in those human clinical trials. Ken Chen at Harvard published a paper which gave us insight into the mechanism behind HER2 perturbation in cardiomyocytes using a Cre recombinase LOX-P system, which selectively knocks out HER2 only in mouse myocardium. If you do a whole organism knockout, that's embryonic lethal, so you can't study the hearts in that situation. So he devised methods where he excised the first exon of mouse HER2 by flanking that exon with 2 LOX-P sites and crossing those transgenic mice with a myosin light chain promoter Cre recombinase mouse strain. And those resulting mice had knockout of HER2 selectively in the tissue-specific knockouts shown in the lower left-hand side of the slide compared to ERB4 or HER4. On the right-hand side of the slide, you can see the phenotype of these conditional knockout mice. There's a dilated cardiomyopathy shown in the conditional knockouts on the far right-hand side of the slide, with a dilated cardiomyopathy, which on transmission electron microscopy has increased vascularization and increase in mitochondria. So we now try to avoid anthracyclines in the treatment of HER2-positive breast cancer. We developed non-anthracycline regimens, in this case TCH, which had high objective response rates, the highest published at the time of these pivotal trials in metastatic breast cancer, and the longest times to progression also were reported in back-to-back papers in the JNCI. And you can see that in 2 of these 50-patient trials, when looking at all left ventricular ejection fractions at all time points for all patients in these 2 studies, that with this regimen, there was really no clinically significant diminution in left ventricular ejection fraction. There were 2 patients, one in each study, with symptomatic declines in ejection fraction, both of which recovered, and those are shown in the dark lines on each of these plots at the bottom of the slide. TCH was studied in the adjuvant setting and shown to be as effective as anthracycline-based therapy when combined with trastuzumab. Moreover, in the dark blue insert in the center of this slide, you can see that the ejection fractions were also maintained in the top red line on that graph compared to the anthracycline-containing trastuzumab combination or anthracycline chemotherapy control. Subsequently, in the neoadjuvant setting in the TRAIN-2 trial on the far right-hand side of the slide, once again, we see that non-anthracycline regimens, when combined with trastuzumab and pertuzumab, yield similar pathologic complete response rates as those regimens that incorporate anthracycline. So anthracyclines are effectively dead now in the HER2-positive metastatic breast cancer space on the basis of these and other findings. We also studied combinations of endocrine therapy with trastuzumab and found that there was synergism between HER2 antibodies and fulvestrant. That's shown on the far left-hand side of the slide, where the combination of HER2 antibody plus fulvestrant, abbreviated as FX in the far left-hand panel of this slide, resulted in a marked decrease in estrogen-dependent gene expression in that experiment. This had physiologic and biologic consequences. In the middle panel, you can see that the antibody plus fulvestrant in the lower row in the middle, highlighted in the red box, there's a marked increase in cell cycle arrest. In this experiment, we used P27 nuclear localization as a marker for cell cycle arrest. You can see there's more with a combination than either endocrine therapy alone or monoclonal antibody alone. This was confirmed by Jha and colleagues on the far right-hand side of the slide, who independently showed very similar results with fulvestrant plus lapatinib in cell proliferation assays. This led to an FDA registrational trial of letrozole placebo versus letrozole lapatinib in HER2-positive, ER-positive metastatic breast cancer. This resulted in an improvement in median progression-free survival from 3 to 8.2 months with statistical confidence. There was also a significant reduction in the risk of disease progression with a hazard ratio of 0.71, also statistically significant. There was an increase in objective response rate, as shown on the right, and an increase in the clinical benefit rate, also shown on the right. This resulted in an accelerated approval for this combination by the FDA back in January 2010, based on a paper we published in the JCO the previous year. Next, I want to talk about the development of a second generation HER2 antibody called pertuzumab, which blocks the dimerization domain of the HER2 receptor, shown on the far left-hand side of this slide. HER2 likes to form dimers with other HER family members, particularly HER3, which is the most active HER2-HER3 heterodimer. It's the most mitogenic in cancer cells. And I showed you earlier that trastuzumab disrupts ligand-independent HER2-HER3 association. Pertuzumab blocks ligand-dependent HER2-HER3 heterodimerization, shown in the Western blot analysis in panel A in the center of the slide. This had important consequences, as shown in the bottom center of the slide in panel B, because the combination of these two antibodies induced apoptosis, whereas either antibody alone had very limited activity to actually increase programmed cell death, but the combination did, even in the absence of chemo. And in the neoadjuvant setting, Luca Gianni and colleagues published data showing that this two antibody combination, when combined with chemotherapy, yielded the highest pathological complete response rates. And Dr. Sandra Swain showed in metastatic disease in the Cleopatra trial, in the first-line HER2-positive metastatic disease setting, that there was a survival benefit by adding pertuzumab to trastuzumab plus a taxane. And this has been updated last year, where with 99-month median follow-up now, this improvement in median overall survival is maintained after all those years of follow-up, with now a delta at the median of 16.3 months improvement in overall survival, simply by adding a second HER2 antibody to trastuzumab plus chemo. Really remarkable result. There have been HER2 selective kinase inhibitors that have been developed. Heretofore, other kinase inhibitors like neratinib, lapatinib, and others are not specific for HER2, because the structure of the EGF receptor and HER2 kinase domains are so similar. It was very difficult in terms of medicinal chemistry to come up with a molecule that would only block HER2 and not other HER family members. But tucatinib is an exception. It's 1,000-fold more selective for HER2 than EGF receptor. And it was hoped that this would decrease toxicities associated with EGF receptor blockade, for example, diarrhea and cutaneous rash. So this molecule was taken through early phase and then late phase clinical development, including the FDA registrational randomized HER2 CLIMB study shown in the lower left. This study randomized 612 patients to either tucatinib or placebo, along with capecitabine and trastuzumab. These are HER2-positive metastatic breast cancer patients with prior treatment with trastuzumab, pertuzumab, and TDM1, so heavily pretreated patients. And brain metastasis were allowed in this study at baseline. About 48% of the patients in this study had pre-existing breast cancer brain metastasis that were HER2 positive. This study met its primary endpoint with statistical confidence. Progression-free survival shown on the lower right-hand side of the slide, hazard ratio of 0.54, so a very big therapeutic impact, high statistical confidence with 4 zeros after the decimal. There was also an improvement in overall survival that was statistically significant at the time of the first planned interim analysis. And also at the first interim analysis, there was an improvement in progression-free survival in the subset of patients with brain metastasis, indeed. Next, we were interested in developing non-chemo-based treatments. And to this end, we looked at HER2 antibody-drug conjugates based on the trastuzumab backbone. And we did some experiments in the lab at UCLA with a paclitaxel conjugated trastuzumab. We found that it worked just as well, at least in animal models, as free paclitaxel plus free trastuzumab. But unfortunately, the small biotech company that was developing this reagent ran out of resources. Our colleagues at Genentech were also interested in antibody-drug conjugate technology, and they were working with a derivative of emtansine payload instead of paclitaxel. They were studying linker chemistries from stable linkers to less stable linkers to see if they could fine-tune the optimal stability versus lability linker combination chemistry. And they found that the best chemistry was a stable linker that is not labeled at all. It requires internalization into the early and late endosome and trafficking it all the way to the lysosome, where the antibody-drug conjugate is degraded all the way down to the single amino acid level, which releases the cytotoxic payload DM1 from within, which is an inhibitor of tubulin polymerization. So this is like a Trojan horse approach as shown in the schema on the right, a novel mechanism of action of this antibody-drug conjugate. This was also taken into phase 3 registrational trials, winning FDA approval. The Amelia pivotal trial pitted TDM1 against capecitabine lapatinib, which was the FDA-approved control arm of the day. The study met its primary endpoint of progression-free survival, as shown on the left, compared to capecitabine lapatinib control, high statistical confidence. Both the investigator-reported responses as well as the independent review committee responses are shown in the left-hand Kaplan-Meier analysis. On the right, we also showed updated overall survival data. This is the end of study survival analysis showing that this antibody-drug conjugate improves overall survival as well. Newer antibody-drug conjugates have been developed, and there are another half dozen or so in development at this time. One of great interest at the present is trastuzumab deruxtecan, which is a cleavable tetrapeptide-based linker as opposed to a stable linker in the case of trastuzumab. This molecule also has a fixed conjugation chemistry, which has a higher payload to antibody ratio of about 8 to 1 compared to about 3 to 3.5 to 1 in the case of TDM1. The payload in this molecule is a topo-1 inhibitor. And basically, there was a recent presentation at this year's ESMO conference of the DESTINY-Breast03 phase 3 trial, which demonstrated superiority of trastuzumab emtansine as compared to control in a patient population previously treated with trastuzumab and a taxane. So this is really remarkable data with improvement in progression-free and overall survival with this antibody-drug conjugate. You can see from the non-randomized phase 2 data in the DESTINY-Breast01 trial on the far left-hand side of the slide that there is an astonishingly high response rate in phase 2 in a patient population with 5 or 6 prior lines of treatment for metastatic disease. So really the most active single agent yet developed for HER2-positive metastatic breast cancer. Finally, I'll mention engineering of the Fc domain to try to exploit this ADCC mechanism of action of HER2 antibodies. This was done by introducing mutations deliberately into the Fc domain of a HER2 antibody, shown on the far left crystal structure, and that increases binding affinity to activating Fc receptors and actually decreases affinity to decoy negative regulatory receptors. A study of this drug called margetuximab, when combined with chemo in HER2-positive metastatic patients heavily pretreated, showed a PFS improvement with margetuximab compared to trastuzumab in a head-to-head study, winning FDA approval also last year. Moreover, patients with these low binding affinity alleles containing phenylalanine and Fc gamma R3A gene sequence had a greater efficacy signal. And that data will be updated, including an overall survival analysis of the FF allele carriers at this year's San Antonio Symposium in December 2021. Stay tuned for those results. So in Dennis Lehman's original Science paper back in 1987, he is quoted as saying in the discussion section of the paper, finally, if the HER2 gene product functions as a growth factor receptor that plays a role in the pathogenesis of breast cancer, development of specific antagonists could have important therapeutic implications. And based on his original Science papers with bookends, if you will, in the clinic with the metastatic pivotal trial that won FDA approval back in 1998, I would say that those are pretty impressive bookends on the HER2 story. Credit to Dr. Slayman and his tenacity to generate all the data leading to approval of trastuzumab. So over time, with improvements in HER2-targeted therapies and new drug classes being developed over time, we've seen that the survival probability is improving with HER2-positive disease as we introduce these new molecules into the clinic. So I've shown you that early discovery research went through the Schopenhauer triad of dismissal, ridicule, and then claiming credit. I've shown you the allosteric activation of HER2, HER3 complexes as an important mitogenic stimulus that can be disrupted by pertuzumab, yielding a huge survival benefit. First-line combined receptor blockade targeting HER2 and ER is highly active and well-tolerated. Tucatinib is a pure HER2 TKI, and it has activity in pretreated HER2-positive metastatic breast cancer, including breast cancer brain metastasis, and it may well be less toxic than other HER2 tyrosine kinase inhibitors. HER2-targeted antibody-drug conjugates are highly effective, though clinicians must be mindful of toxicities. Alternate linker payload chemistries can be non-cross resistant. And finally, Fc-engineered chimeric HER2 antibody margetuximab rehabilitates HER2 antibody responses in low-affinity Fc gamma R3A F allele carriers. Next, I'd like to talk about patient selection for these HER2-targeted therapies with consideration of potential toxicities. This is the current NCCN guidelines for HER2-positive metastatic breast cancer. And you can see in the first line, the Cleopatra-like regimens, as I showed you, with a huge survival benefit from pertuzumab combined with trastuzumab and taxane, still carry the day on the first line. Heretofore, until this year's ESMO, second line had been firmly TDM1, but now that's been challenged by the DESTINY-Breast03 fam-trastuzumab deruxtecan data showing superiority of TDM1 in the second line, second and greater line, I should say. And then finally, third line and beyond is a mixture of small molecule inhibitors like tucatinib, antibody-drug conjugates, chemo trastuzumab combinations, margetuximab, neratinib plus chemo combinations, et cetera. Note on the bottom left that the NCCN committee has specifically called out a benefit of tucatinib in those patients with HER2-positive breast cancer brain metastasis. I'll show you the data to support that in just a minute. And then they also suggest that fam-trastuzumab deruxtecan is preferred in patients with visceral metastasis if progression on prior TDM1. So that was the state of affairs up until recently. So let's show you some data that supports these NCCN guidelines. This is the HER2-HER3 heterodimer shown in the upper left-hand side of the slide. As the receptors dimerize, it brings together the cytoplasmic domains, which is the business end of the HER2 kinase molecule. The enzymatic activity resides there. HER2 can phosphorylate HER3 on 6 tyrosine residues in the cytoplasmic domain, shown in the center bottom of this slide. HER3 has the highest number of phosphotyrosine residues that bind to PI3 kinase, higher than any other protein in humans. And I showed you previously on the bottom right-hand side of the slide that HER2, HER3 has the highest signaling activity of any pair of HER2 containing dimers in the whole HER receptor family. And finally, the upper right-hand side of the slide, I'm showing you some new crystal structure data of HER family receptors. This is examples of HER3 and EGFR in the middle top part of the slide, but it's assumed that the HER2, HER3 structure is similar. And it's ironic, perhaps, that the structure resembles that of cyclin CDK2 complexes. So in evolutionary terms, the HER2 kinase domain has evolved from a CDK2 cyclin structure. You can see the N lobe structure is the same, the C lobe with those parallel alpha helices. You can see this coiled alpha C helix is shared between the two structures. So really remarkable similarity between those two families of kinases. This is the Cleopatra study that I showed you previously with this 16.3-month improvement in survival simply by adding pertuzumab to chemo and trastuzumab in the first line. Note that the most common adverse events are shown at the bottom of the slide. When you add pertuzumab, there is a little bit increase in myelosuppression and also some increase in diarrhea. Oftentimes the diarrhea can be mitigated simply by reducing the docetaxel dose and continuing with the dual antibodies. There are studies underway as we speak trying to improve upon the Cleopatra trial results. In this case, with a CDK inhibitor for those patients that are both hormone receptor positive and HER2 positive in the first-line metastatic disease setting. After finishing the chemo phase of the Cleopatra regimen, we often will layer in endocrine therapy along with the dual antibodies, and this study will randomize that strategy plus or minus the CDK inhibitor palbociclib. So this will test the hypothesis that CDK inhibition along with HER2 targeted therapy will result in a therapeutic advantage. Moreover, in another similar study design of the Cleopatra-like regimen in the maintenance phase, while you're still on the dual antibody maintenance, for those patients that have PI3 kinase mutations, patients will be randomized in this EPIC-B2 trial to receive alpelisib, the alpha-specific PI3 kinase inhibitor, or not, for those PIK3CA mutant HER2 positive patients. Of course, there's a run-in study at the top in a phase 1B portion of the study to select the correct alpelisib dose in terms of tolerability with the dual antibodies, and then the randomization will be placebo-controlled as shown in the schema in the bottom. And then finally, the NRG-BR004 study will test whether integration of immune checkpoint inhibition, in this case with the atezolizumab, will be effective in HER2-positive metastatic breast cancer in the first line by randomizing a Cleopatra-like regimen with weekly paclitaxel plus the dual antibodies plus or minus atezolizumab in this placebo-controlled randomized phase 3 trial. I've already shown you the data on TDM1 and how this stable linker chemistry allows for internalization, trafficking to the lysosome, then degradation and release of the DM1 payload from within, and how that also has improved progression-free and overall survival of previously treated HER2-positive metastatic breast cancer. It's important to point out that with the success, there are some toxicities associated with TDM1, as shown on the bottom of this slide, including fatigue, nausea, musculoskeletal pain, thrombocytopenia, headache, and transaminase elevation, sometimes even constipation. So clinicians must be mindful of these adverse events, and there are dose modifications for TDM1 as shown on this slide. And the package insert has a wealth of information about when and how much to reduce the dose depending on the grade of toxicity observed. In this example, I'm showing you the hepatotoxicity warnings and precautions. And you can see for grade 2 transaminase elevation, you can treat at the same dose, but if it gets up to grade 3, then dose reduction of 1 dose level is indicated. And if you get up to grade 4, then permanent discontinuation of TDM1 is indicated. This is trastuzumab deruxtecan, as I've shown you a little bit about before. Again, a high antibody-drug conjugate, drug-to-antibody ratio, I should say, DAR, drug-to-antibody ratio of 8, as shown on the upper right-hand side of the slide. A cleavable linker that's tetrapeptide-based. The payload, in this case, a topo-1 inhibitor, is membrane permeable. It's a soluble payload, whereas DM1 is not. When DM1 kills a cancer cell, it cannot diffuse into adjacent tumor cells and kill them also, whereas this payload, deruxtecan, can have that effect. So bystander killing is a unique attribute of trastuzumab deruxtecan. And trastuzumab deruxtecan has a higher dose than TDM1, which may also be an advantage if some of the antibody mechanisms are maintained in these antibody-drug conjugates. This is the pivotal DESTINY-Breast03 trial that was presented at ESMO, a randomized phase 3 trial in metastatic HER2-positive disease previously treated with trastuzumab and a taxane in an advanced or metastatic setting. These patients could have clinically stable treated brain metastasis. About 20% of the patients in the study had breast cancer brain metastasis. The stratification factors for this trial were hormone receptor status, prior treatment with pertuzumab, and a history of visceral disease. Patients were randomized 1-to-1 to TDXD versus TDM1, as shown in the scheme on the top left. The top right shows the primary endpoint of progression-free survival, which was met with statistical confidence with a p-value of 10 to the negative 22nd. Astonishing results from a statistical point of view. Hazard ratio 0.28, the lowest I've ever seen for a HER2-positive randomized phase 3 trial. The objective responses are shown on the lower left. So very impressive waterfall plots. Response rates nearly 80% in the TDXD arm compared to TDM1 of only 34%. The overall survival data is shown for your reference on the lower right-hand side of the slide. These data are immature despite a hazard ratio of 0.56 and a p-value of 0.007. This did not meet the pre-specified target p-value at the time of this first planned interim analysis. So more time is needed for mature overall survival data in DESTINY-Breast03. The data was consistent across key subgroups as shown in the forest plot analysis, irrespective of hormone receptor status, prior pertuzumab exposure, visceral disease, prior lines of therapy, or breast cancer brain metastasis versus not. All of these subgroups benefited significantly from TDXD as compared to TDM1. Now, like other important drugs with efficacy against HER2-positive metastatic breast cancer, we must be mindful of adverse events, and TDXD is no exception. As opposed to TDM1, TDXD has more chemo-like toxicities, including myelosuppression, as shown on the left, GI toxicity, some fatigue that sometimes requires dose modification. Transaminase elevation can also be a feature of this antibody-drug conjugate, as it can be with TDM1 as well. Anorexia is also another feature of this reagent. Indeed, alopecia is seen more frequently with TDXD as compared to TDM1. Importantly, in this randomized phase 3 DESTINY-Breast03 trial, we did not see any grade 5 toxicity in terms of interstitial lung disease or drug-related pneumonitis, as we had seen in the phase 2 data, which unfortunately had a 2.7% incidence of grade 5 ILD. Unfortunately, this was not a feature of the randomized trial, probably because the patients in the randomized trial were less heavily pretreated. About half the patients were treated in the second line, and the other half were third or later line, whereas in DESTINY-Breast01, patients were treated with a median of 5 to 6 prior lines of therapy. Moreover, in the conduct of this phase 3 trial, now that the ILD situation was better understood, probably early recognition and early intervention, for example, with steroid treatment, probably helped to prevent escalation from, let's say, grade 2 or 3 to grade 4 or 5 in this trial as well. These are dose modifications that are from the prescribing information for trastuzumab deruxtecan. I'm showing you the example from the package insert for management of ILD or pneumonitis. And you can see that if there's resolution, you don't need dose modification, but if it takes more than 28 days to resolve, then you should reduce by 1 dose level. If you see symptomatic ILD, that is grade 2 or greater, then you are to permanently discontinue trastuzumab deruxtecan. Here's a very nice algorithm for management of drug-related ILD in the case of trastuzumab deruxtecan. The first maneuver is drug interruption, because that can be a diagnostic maneuver as well, because if patients get better clinically after drug withdrawal, that can support a diagnosis for drug-related ILD. Note that confirmation in the middle top of the slide includes consultation with a pulmonologist early on, as clinically indicated. High resolution radiographic imaging may also be helpful. And then management is shown on the far right-hand side of the slide, as I mentioned, from the prescribing information. The timing of the onset of drug-related pneumonitis in the case of trastuzumab deruxtecan is shown in the bottom of the slide. It appears from the earlier phase 2 data from DESTINY-Breast01 that most of these cases occur in the first 12 months of treatment. So that's when to be particularly on the lookout for interstitial lung changes. But it can occur later. There's a case there beyond 18 months, as you can see in the plot on the lower center of this slide. Now, based on the strength of the DESTINY-Breast03 randomized data, trastuzumab deruxtecan is now poised to challenge Cleopatra regimens in the first-line setting in this DESTINY-Breast09 phase 3 pivotal trial, where TDXD will be compared to TDXD plus pertuzumab versus taxane, trastuzumab, and pertuzumab. And so this will be a very interesting trial that could be practice-changing if positive, and may be one of the first trials to beat a Cleopatra-like regimen. Next, I'm showing you two new small molecule tyrosine kinase inhibitors that have been approved for HER2-positive metastatic breast cancer. I've shown you some of the data about tucatinib previously, and the top of the slide and the bottom is the NALA study, which was the FDA registrational trial of capecitabine plus neratinib that won FDA approval a couple of years ago based on the PFS data shown on the lower right-hand side of this slide. Now, the NALA trial was challenged by GI toxicity in the form of diarrhea due to neratinib. We now have nice data showing that a dose escalation approach where you start with 3 tablets initially and then graduate to 4 and then to 6, that can greatly decrease the grade 3 or higher diarrhea incidence with this neratinib capecitabine combination. And so be mindful of the risk of diarrhea with this regimen, and either use this escalation strategy along with PRN anti-motility agents, or use high-dose loperamide prophylactically indeed. I mentioned that tucatinib has unique activity in the brain that's shown in the upper left-hand side of the slide, where we've seen objective response rates in patients with HER2-positive breast cancer brain metastasis, an objective response of 47%, unprecedented for the tucatinib-based HER2 Climb regimen. Also on the upper right-hand side of the slide, you can see that there's an overall survival benefit with statistical confidence and a hazard ratio of 0.58 in the patients with breast cancer brain metastasis in the HER2 Climb study. And even in patients on the lower left with active brain metastasis, they also had a survival benefit with a hazard ratio of about 1/2 in the HER2 Climb study. And finally, on the lower right-hand side of the slide, tucatinib has been shown to either delay or decrease the probability of new brain lesions in this analysis of new brain lesion-free survival with the Kaplan-Meier plots shown on the lower right-hand side of the slide. So hopefully delay the need for future radiation or neurosurgery with the use of this agent in patients. There is important safety information for tucatinib. Diarrhea can be a consequence of tucatinib, and especially when it's combined with capecitabine, which is well known to cause diarrhea in its own right. Tucatinib, as I've shown you previously, can increase transaminases, which may require a dose modification. Obviously, you don't want to give this to pregnant or lactating women. The most common adverse reactions that were serious with tucatinib were diarrhea, nausea, vomiting, abdominal pain, and seizures, probably for from the breast cancer brain metastasis subset for the SAEs. The most commonly reported adverse events of all kinds are shown at the bottom of the slide, and that is diarrhea, palmar-plantar erythrodysesthesia, nausea, fatigue, transaminase elevation, vomiting, stomatitis, anorexia, abdominal pain, headache, anemia, and rash. There can be lab abnormalities, as I mentioned previously, from tucatinib, particularly transaminase elevation. There can also be a benign increase in serum creatinine, which is due to creatinine transporters in the renal tubule. So this does not impact glomerular filtration rate, but it's an artifact of tucatinib treatment. So you don't need to get renal consultations or do any further testing, as long as the creatinine stays probably around 1.4 or so or less. That's probably just drug effect. Also, tucatinib can have drug-drug interactions to be mindful of if patients are taking other medications for other conditions. Be mindful of the CYP3A or CYP2C8 inducers. Strong or moderate CYP2C8 inhibitors also can result in drug interactions, increasing the risk of tucatinib toxicity. CYP3A substrates may need to be avoided, especially if they are the higher risk substrates that have a narrow therapeutic index. And finally, P-glycoprotein substrates may increase the toxicity associated with the P-glycosubstrate co-medication. These are dose modifications from the prescribing information for tucatinib. You can see there are 3 dose levels to choose from, and I'm showing you examples taken directly from the prescribing information from the package insert for management of diarrhea, hepatotoxicity, and other adverse reactions, depending on the severity of adverse event. And these guidelines are available for your review online and are very easy to use and simple to follow. In an exploratory analysis of the HER2 CLIMB trial in patients with or without visceral metastasis, it was shown that patients with visceral metastasis also fare better when randomized to tucatinib compared to placebo, with a hazard ratio of 0.7 and a p-value of 0.004. So there was really no difference in outcome in patients with visceral metastasis when treated with tucatinib. And I showed you this data previously about margetuximab and these FC-engineered strategies to enhance ADCC and the impact that this has on low affinity binding alleles in particular. And this data will be updated at San Antonio in December of 2021. The margetuximab engineered antibody does have some special toxicities, namely at the bottom of this slide, I'm showing you the infusion-related reactions, which was higher frequency as compared to trastuzumab plus chemotherapy. All of the other adverse events were almost identical to trastuzumab plus chemo. So it's really this infusion-related reaction that was a standout in terms of frequency, 13% versus 3%. But fortunately, very few of these are grade 3 or greater, only 1.5%. And nowadays, infusion nurses are well versed in management of infusion reactions. As long as there's early intervention, dose interruption, slow down the rate of infusion, and co-medication with antihistamines, et cetera, can usually mitigate against this infusion reaction toxicity. So in conclusion, I've shown you the concept of line of therapy in metastatic disease and how the NCCN historically has considered first-line Cleopatra-like regimen as a go-to regimen, second-line TDM1 as a go-to regimen, and third-line beyond a menu of different options to be discussed with patients in equipoise, perhaps based on their strengths and weaknesses in terms of efficacy versus safety signals. However, this paradigm is being challenged, number one, by the fact that now it's not uncommon for early breast cancer of earlier stage 2 or 3, for example, to be treated with the dual antibodies and maybe even TDM1 in the adjuvant setting if they don't have a pathologic complete response following neoadjuvant therapy. So what do you do then in first-line metastatic disease if it occurs early on in the life of a metastatic patient? Do you want to recycle these same treatments that the patient just recently progressed on? Probably not. So this concept of line of therapy is being challenged in the modern era as we move these drugs up into the early disease setting. And so from my point of view, I think we should characterize lines of treatment of metastatic disease based on prior therapy and how long ago it has been since the last exposure to the prior therapy, rather than the concept of lines of therapy. And finally, based on the DESTINY-Breast03 data that was presented at the 2021 ESMO conference, this is Dr. Shanu Modi's take on new guidelines for the treatment of HER2-positive metastatic breast cancer post-ESMO 2021. The Cleopatra-like regimens are still in the first line, but now in the second line, based on the strength of the DB03 data, trastuzumab deruxtecan has been promoted into the second line, except for patients with CNS metastasis, where tucatinib-based treatment has level 1 evidence of a survival benefit and carries the day for breast cancer brain metastasis. In the third line, there can be equipoise between TDM1, or if the patient hasn't had prior tucatinib, then the HER2 CLIMB regimen can be considered there. And then in later lines of therapy, margetuximab chemo, neratinib, capecitabine, and trastuzumab lapatinib are other combinations for your consideration. Thank you very much for your attention. I hope that my comments will be helpful to you in your clinical practice and especially helpful to your patients. Please be mindful of not only the efficacy signals that I've shown you, which are particularly exciting in light of new data that's just been presented in the last year to a year and a half, leading to 3 or 4 new FDA approvals just in the past couple of years for HER2-positive metastatic breast cancer, but also be mindful of potential toxicities in addition to the exciting efficacy, and make those modifications, dose adjustments, withhold drug treatment as needed if clinically indicated, and work your patients up and screen them carefully for expected adverse events. Thank you so much, And once again, thanks to our sponsor, CancerNet, and also support from the sponsor, Seagen.